How does the toxic CoV-2 spike protein accumulate in kidneys? Can the toxic CoV-2 spike protein S1 fragment, which has a molecular weight of about 75 to 125 kilodaltons, depending on its glycosylations, can this S1 fragment pass through injured fenestrae in renal peritubular capillaries? That question can be addressed by looking at the molecular weight of human serum albumin, which is 66.5 kilodaltons. So human serum albumin is in high concentration in the serum, but in low concentration in the interstitial fluid surrounding nephrons. This is because of the diaphragms in these fenestrae. They block the large molecular weight globular protein, human serum albumin, from passing through the fenestrae. So if the fenestrae became injured and the diaphragms were lost, it would be possible that human serum albumin could pass directly from the serum to the interstitial fluid of the kidney. But at this point in time, there's no direct evidence of that. It's just a hypothetical condition at this point in time. Much more probable is that the spike protein S1 fragment during a COVID infection circulating in the serum could pass through disrupted tight junctions in peritubular capillaries. These tight junctions hold the endothelial cells together, and under oxidative stress or the toxic actions of viral proteins, spike protein S1 fragment, or the CoV-2 envelope protein, or other toxins, the loss of these tight junctions would open very large pores that would allow components of the serum to enter the interstitial space. Loss of tight junctions in the endothelial cells and/or loss of diaphragms inside fenestrae would produce serious permeability problems in peritubular capillaries, leading to disruption of renal functions. However, if the fenestrae and their diaphragms remain intact, these pores in the peritubular capillary surface are going to be playing critical roles in the pathogenesis of COVID and long COVID, as well as its treatment. Reading from the information vector at the bottom of the slide, here is a set of small molecular weight signaling molecules. Some of them are pro-inflammatory, others are anti-inflammatory. Others are key hormones or hormone analogs, synthetic versions of endogenous hormones. Calcifediol, the liver vitamin D metabolite, an active hormone that can activate vitamin D receptors. Calcitriol, the kidney metabolite of vitamin D, the most powerful immune hormone in the body. A synthetic version of calcitriol, paracalcitol, 125 vitamin D2, the preferred therapeutic agent to treat calcitriol deficits in renal patients. Arachidonic acid, formed by the actions of phospholipase A2, a pro-inflammatory lipid. It is upstream of the production of three classes of pro-inflammatory molecules: prostaglandins, leukotrienes, and thromboxanes. Arachidonic acid can be modified by epoxygenases to become EETs. EETs are anti-inflammatory. They also promote healing of injured tissues. So all of these molecules within the set, because they are small molecular weight compounds, they can easily pass through these pores, the fenestrae, and their diaphragms in renal peritubular capillaries. And because of that, this transport is going to be critical for pathogenesis as well as healing. And so the discussion of therapeutic agents is going to come back to these structures, and we will address that in future YouTubes.